there, I have praised the article Prevention of Bradycardia by Atropine Sulfate during Urological Laparoscopic Surgery, a randomized controlled trial, which was written by Dr. Edgardo Hamadi and others. This study was a randomized controlled trial where the participants were blinded by the use of a placebo. It aimed to assess whether prophylactic atropine prevented bradycardia during the laparoscopic surgery. This closely corresponds to our clinical question and was found in the search methods aforementioned by Luke. 64 patients undergoing laparoscopic surgery were randomly assigned into two groups. One received atropine and the other received saline 3 minutes before induction. Heart rate was recorded at several intervals during the operation, before and after. There were no differences other than this between the two groups. The study found that 9 out of 32 patients in Group 2, which is 28%, developed bradycardia, which was defined as a heart rate less than 60 beats per minute, while none of the patients in Group 1 had bradycardia perioperatively. This had a p-value of 0.001, which is statistically significant. This indicates that atropine had a significant effect in preventing bradycardia during laparoscopic surgery. There were both advantages and limitations of the study, which I will run through now. The study had a well-defined research question that could be answered using a randomized control trial, assessing whether atropine prevented bradycardia compared to a placebo. While it was not a double-blinded test, this is not significant because heart rate is an objective measure. The study design is sound as the only difference between the intervention and the control groups was the use of atropine or placebo. The inclusion and exclusion criteria was appropriate for the study. Each exclusion criteria included history of cardiac disease, which was explicitly defined in the article. A limitation of the study is that it does not state how many people were excluded because of these criteria. Selection bias was reduced as all of the participants agreed to do the study, so the eligible and participating populations were the same. The baseline characteristics of the two groups were similar. There was a non-statistically significant difference in ages with a p of 0.06. However, the control group was younger and therefore it is likely that this would minimize the effects that were seen in the study. There were no other baseline differences, including sex and heart rate preoperatively. The study had ethical approval, which was explicitly stated, and there were no competing interests for the study. Aside from the limitations I've already mentioned, there were some further limitations to the study. The study did not mention asystole or sudden cardiac death. However, in the introduction, it did say that this was a possible rare complication, and it is assumed that this did not occur in any of the patients. However, this should have been explicit. Furthermore, there is no explicit recording of any side effects that may have been caused by the use of prophylactic atropine. Furthermore, it was quite a small population size, which increases the risk of sample bias. However, the results were statistically significant, which indicates the strength of the results. It is unclear how generalizable the results are, as the population group was not explicitly stated, and it is unclear how similar this group is to patients at Wellington Hospital. However, the procedure does appear to be very similar to the one used in Wellington and is explained in detail in the article. Overall, this is a study that is well designed to minimize bias, and it produced a statistically significant result that indicates atropine is effective in preventing bradycardia during laparoscopic surgery. Thank you.